Good morning, everyone. I'm like straight up on top of the hour, so I think we'll get started. I'm Cherie Boxberger, Regional Vice President for Heart Failure and Resuscitation for the 6-state Southwest affiliate of the American Heart Association. And I'm joined by Julie Blakey, Director of Quality and System Improvement for Colorado, and she's also our affiliate lead for resuscitation. I apologize in advance for my voice. I woke up this morning and this is how I sounded. So I have my lemon water here, and I'm sure I'll get better. There was no one to speak with here in my office, so I apologize. So welcome to the Resuscitation Quality Exchange, and this is a quarterly webinar to allow hospital teams who are working diligently to improve hospital survival from cardiac arrest to come together, learn, share, and identify resource needs. And I hope you'll invite your colleagues to join us. Everyone is welcome on this call, whether or not you utilize Get With the Guidelines resuscitation. If you have a colleague who's working with their Code Blue team at any size of hospital, please invite them. And if you want us to reach out to them, you can just send us their name, hospital, and email at SWA, and I'll say this quite a few times today, SWAquality@heart.org. And that's Southwest affiliate. And let's see, we are also holding quality exchange calls for heart failure and for stroke, and those are held every quarter also. So you have been placed on mute, but I would love for you to join in the conversation, and to do that, you just *6. And you can also turn yourself on and off that way. *6, you're on, *6, you're off. We're going to have several points in the call today where I will ask you to share as an added incentive. Anyone who shares on the call today, gives a best practice, or is able to contribute in that way. We have a really nice little laminated shopping bag that we're going to send out to everyone who is able to share with us today. So be thinking at what you're doing at your facility that you really are proud of, or if you have something that you're really struggling with and you want us to reach out and get a broader input into solutions for that. So let's get started. So this is our agenda. We're going to talk about data deadlines because we are up against an award period. Do a quick journal review of a number of articles, one that just came out last week. I want to have a little bit of time. Some of you are abstractors who are on the phone, and just review the most recent coding instructions just to make sure. We're not going to review the coding instructions, but review that you're using the latest. I'm going to give an advanced reporting demo. A lot of our folks, when they're learning the patient management tool, haven't had the opportunity to dig down into filters and some of the things that are helpful. Best practice sharing, and I am happy for you to share whatever you'd like. One is what you're most proud of about your Code Blue team. Another question might be CPR quality. What are you doing on your Code Blue team to assure CPR, high CPR quality? Or, you know, another question might be, who is the champion of your Code Blue team? So think about some of the things that you're doing well that you can share with us. I'm telling you that early so you can be thinking. We'll also introduce Resuscitation Quality Improvement, a new AHA initiative, as well as, while it's not related directly, we are introducing all of our teams to Get With the Guidelines atrial fibrillation, just a short update. Now, if there's anything that you would like to be covered on this agenda that is not, this is a great time for you to *6 and say, Cherie, I want to hear about whatever it is. So anyone wanting to hear something different, or that you're sorry to see it's not on here, *6 and let me know. You also have access to the chat box. Michelle Martinez from American Heart Association is joining us today as our moderator, and so she will be looking at that chat box, answering some questions there as well, and contributions through the chat box also are eligible for the tote bag. All right, let's get going and talk about data deadlines. So all the 2017 discharges need to be entered by the end of February. And this is kind of how it'll lay out. You'll enter them by the end of February. And if you enter them before, let your director know. You should have received an update on your current data abstraction through, I believe, the 17th of January. any discharges through that point. And so you should be up to date on what your current state is. Get the rest of those entered, and then during March, that is a time for us, for your quality improvement director to run your reports, evaluate the data, and make sure you're all set for recognition. You will recall that we have one measure that you can either use the current measure, and that is the airway verification, that you can use it. If you are not meeting that, we can run the historical data point for that as well. So I'll show you that when we're in the demo. Just a warning, do not adjust your 2017 data once you have confirmation from your director that you are award level. I apologize for that typo there. But once she says or he says you're good to go, do not fiddle with the 2017 data. And now, once we've pulled the data, April 1st or thereabouts, and we'll let you know what that date is exactly, then you can make adjustments in your 2017 if you need, things that have come up that you've learned from a physician or a change in documentation. So early April, all the data is pulled for awards. You don't have to put in an application. You know, we used to have to do that. In approximately May, the awards will be announced, and we'll send out emails from your director. Just so you have an idea, June, the abstracts for scientific session or resuscitation sessions, which you realize is attached to scientific sessions, those are going to be due in about June. You are probably doing work right now that would be eligible for an abstract, for a poster, or a presentation. So be thinking about what quality improvement work you've been doing that we could put together into a abstract submission. Your director of quality or myself, we are glad to help you. You're doing a lot of good work out there, and that's the kind of thing we want to hear at scientific sessions. In July, the U.S. News and World Report ad will be out for the gold and silver hospitals, and then in November, gold and silver hospitals are recognized at scientific sessions. I think that's November 10th to the 14th in Chicago. Any questions about data deadlines? *6 to ask, or you can also type them in the chat box, and Michelle will be glad to help you. Great. All righty, let's hop into some journal review. Some of the things we want to do on this call, because you are very busy clinicians, is to be able to just bring to your attention publications that are related to resuscitation. And so this is one just came out January 22nd in JACC. Cardiac survival is lower on nights and weekends. Very interesting article. They looked at the entire population, and as we are often quoting, and this did come out of Get With the Guidelines Resuscitation, just so you know, another reason why when you participate in Get With the Guidelines Resuscitation, you're actually contributing to national and international research. So survival has improved. They did this from, I believe, 2000 through 2014. Survival improved in both the on and off-hour patients. However, survival to discharge in patients who are arrested during off hours was an absolute 3.8% lower compared to patients who are arrested during on hours. A previous study found rates of survival and neurological outcomes were 15 to 20% lower among patients who are arrested during nights or weekends of off hours. And just so you know, in this database, nearly 50% of the arrests occurred off hours. And according to the researchers, they looked at the things that they listed as potential were, why does this happen, is changes to hospital staffing patterns during nights and weekends, and we all know that occurs. Physicians working nights and weekends to provide coverage to patients may be less familiar, I apologize, I'm missing some words, with the guidelines. Nurse-to-patient ratios are often lower during off hours, and these are all things you know. And the impact of shift work, particularly during nighttime, has been shown to impact psychomotor skills, performance of skilled activities, and we know CPR is one such activity. So this is really interesting, and this is something through Get With the Guidelines that you can take a peek at and see how you're performing as it relates to not only the day of the week, and I'll show you how to do that simply, but also you can export your data and look at all of your patients based on your weekend and off-hour survival. So this is really an important element. I know that all of us, when we're talking about guideline-directed medical therapies, we want that to be 24/7, 365. We don't want in our hospitals to have times where we know the care is not at the same level. So I direct your attention to this article. This happens to just be, I'll attach the press release when we send it back out, but you can search this. It's from last week. Any thoughts, ideas about this? If you've been studying this at your hospital and you're working on it, this would be a great time to share. Anyone *6 and tell us what you're working on related to nights or weekends? Anything going on out there? Remember, I have these nifty tote bags for everybody who contributes to best practice or tells us what's going on. All right, you could think about it. That'd be a good thing to offer when we have our open session. All righty, there have been 13, actually this will make it 13, 13 publications out of Get With the Guidelines since January 1st last year. So I wanted to go through a few of those. I'll give you a snippet of the results, but these are things that you could go and look at. The first one does relate to the article we just saw related to the adult population, and that is the survival rate in the pediatric measure. So that's kind of interesting because they were looking at nights and weekends with the pediatric population. And the conclusion in this was the rate of survival to hospital discharge was lower for pediatric CPR events that occurred at night than for CPR events that occurred during the daytime and evening, even after adjusting for many potentially confounding patient events and hospital-related factors. Again, an area of concern where we need to be evaluating, implementing quality improvement mechanisms. You can get data out of your Get With the Guidelines resuscitation that you can take to leadership to demonstrate the need either for additional staff, resources, that kind of thing. So if you want to talk more about this, but here is, we'll send these out so you can look them up. The second one, acute respiratory compromise in the ED, a description and analysis. So in this one, patients who had acute respiratory compromise in the emergency department had an in-hospital mortality of 34%, and these patients have a high risk of progressing to cardiac arrest with a subsequent increase in hospital mortality to 82%. So it's important as we're looking at those patients where we're thinking it's respiratory, we're looking that, remember, we want to be able to keep them from going to the next level. So sometimes the emergency department may have their own processes. They may be separate from what you're doing with your MET team. They should not be. We want to have those tied in. So interesting article. The third article has to do with early intubation. And so in that situation, the findings do not support early tracheal intubation for in-hospital cardiac arrest. And I think they used 15 minutes is what was described as early. Again, feel free to go to these articles. I'm kind of doing a very short snippet of the results. All right, predicting in-hospital mortality for folks who initially survive ARC and what that looks and what they did in this is really interesting, is they created a model where it was a prognostic score so that you could look and see which patients who have acute respiratory compromise are most likely proceed to cardiac arrest. So that might be a tool that you can use. Now, something I've always wondered about, having been associated with an academic medical center when I worked in hospitals, is this issue around the July effect. And those of you who train residents know that in July, then you have to teach all your docs how you need them to do things. So this was interesting, is the association between that physician turnover and survival after in-hospital cardiac arrest. And the results were mixed. This is an interesting article. Most survival models showed a statistically significant difference, but this was not supported when they did the secondary analysis about ROSC and how they were neurologically. So in this article, they actually found no July effect in the emergency department or the med-surg ward for patients with in-hospital cardiac arrest. So take a look at it, because I know anecdotally many of us have thought that there must be a July effect. And one last journal article, and I'll go through the second half. We'll look at those in April, but I'll send the whole list to all of you. This is interesting, frequency of MET team activation prior to pediatric CPR. So, you know, are we getting those MET teams identified early? Are we calling on them early? We want to increase the number of MET team activations. So the majority of pediatric patients requiring CPR did not have a preceding MET evaluation, especially those that had bradycardia or a cardiac arrest. So they did not have a preceding MET evaluation, despite many of them meeting the criteria that could have triggered the MET. And that suggests opportunities for more efficiently using MET teams in routine care. And when we get to our open session, tell us what you're doing with your MET teams. How are you getting more people to activate the MET teams? I'm also interested in how you're getting visitors, if they're involved in your process, to be able to activate the MET team. All right, that's the journal review. Any specific questions? I don't know that I can answer related to the articles, but things that stand out that you want to ask or share related to these articles. Star 6. All righty. The latest coding instructions, for those of you who are on, the latest coding instructions are August of 2017. If you wonder what happens when you open up your coding instructions and they're highlighted, that is what is new in that particular set of coding instructions. So you'll always see the date highlighted, but if you look down inside the coding instructions, you'll also see what was new in that, and the addition of airway confirmation, both in transferred in patients, moved patients, patients who didn't arrest in your area, as well as those who did, was the change in August with the adult population. Something I've noticed that people don't really know, and I want to show you here, is a lot of people print out their coding instructions, which is great, but they are very difficult to search. So I want to show you a good way to have them on your screen. Always, when you get to the page that has the coding instructions, do print coding instructions. When you do that, it will make them into a PDF, and then all you have to do is right-click, and you can find what you're looking for. And I know some of you, this is like so rudimentary, but I find this a really handy tool that not everybody knows. And so then if you put in something you're looking for, then it will actually find that throughout the document. And this is just a lot faster way to look at your coding instructions than trying to go through a notebook. Anyway, just a little hint. Okay, get back here. I wondered if some of you knew that, I know most of you on the call who used it with the guidelines resuscitation have taken the abstraction certification test, and then of course we ask you to recertify on that every 2 years, so you get emails regarding that. But I wasn't sure if you're aware that you can also have other users of your Get With the Guidelines resuscitation that are observation only. So these are people, might be in leadership, might be in quality, other adjunct areas, maybe even physicians, who want to be able to run the reports, but they will never abstract. So if you have people on your team who would benefit by getting access to Get With the Guidelines and the reporting, you can work with your director of quality to make that happen and to get them accounts. They do not have to take the abstraction test, but they will have access to just the reporting parts of Get With the Guidelines resuscitation. If you have questions, you can type them into the box, and then Michelle will answer those, or at the end she'll read them off to me so that if there's anything she can't answer. All righty, well, your patient management tool, I'm sure many of you have spent an inordinate amount of time in your patient management tool, which we call the PMT, and all of you know how to probably know how to add patients, review the data, how to get your reports, and that you have resources in this little thing that some people call the file cabinet and I call the suitcase, but there's lots of resources. But not everybody is aware that you also have some other items, like this little section, resuscitation. This is actually an online training unit for you to be able to evaluate the tool, how to enter data, how to get around in the system, basic running reports. So it is a very nice, it's got audio, and it moves from screen to screen. It's not just a PowerPoint. So I encourage you to take a peek at this. Even people who've been abstracting for a while, I think will find some good information in here. You also have access to some training, online training for advanced reporting. And I'm going to show you a little more about this, but this is looking at filters, how you want it to display, and how you can get your data out of the system in PDF or in Excel. And then there's also a section where they train you on downloading. You can download some or all of your data into a spreadsheet. You can take it all out and be able to look at it. This would be the tool you would use to be able to look at your cardiac arrest survival by weekends and by after hours. You could do this through a spreadsheet. So let me show you a little bit. I wanted to show you a few things that you may or may not know on the, no, nope, I don't. Oh, here we go, outcome. I apologize, I thought it was logged in. Isn't that always what happens when you get out of the PMT? You're like, oh, I'm not logged in anymore. Stop sharing just for a moment while I get this back up. Okay, here we go. All righty. So, and this is a demo site. You're certainly not looking at anybody's information, but a few things I want to point out to you about Give Us the Guidelines resuscitation. Again, very valuable, maybe the most valuable thing is this resources, which is right by your resuscitation. You have in there your blank forms, your latest coding instructions. Always be sure, we'll try to email you, but be sure you're using the most recent coding instructions, the actual measure descriptions, as well as you may have noticed that when you're inside Get With The Guidelines, you are being benchmarked against some different groups. Read this article if you wonder how those benchmarks are determined. An important element of benchmarking is down here, right here, update resuscitation site characteristics. This is a very important area to look at, where this is where you're telling the system who should be your benchmarks. So you're not only giving us your phone number and those things, but look, we've got this hospital at 156 beds. So the benchmarks related to that are going to be in the 156 beds. Also, you're going to have regional benchmarks that are based on the mailing address that you provide us. So you might look at that. Also, and I think there's a place for you to be able to put our main contract folks, and then here's your resuscitation questionnaire. Make sure you have this in. Your bed size for CPA, your bed size for MET, pediatric only, if it's pediatric beds, and what level of newly born you have. These will drive your benchmarking groups, who you can compare to. I encourage you to go in and look at this, and of course there's also the opportunity to update your business side of that, but today we're just talking about the clinical side. So let me get back home. And recircling. All right, we're back. All right. A few other things. This is where those items, those trainings are that I spoke with you about. Very, very important, and soon those of you who have a full year of data will have, this is an important point right here, this is the risk-adjusted survival to discharge report. I believe this is probably the biggest advantage to having Get With the Guidelines resuscitation is that annually, if you go out there now and you have adequate 2016 data, you will have had this report for 2016. If you've been on the calls with Dr. Paul Chan, he has demonstrated to us the importance of using a risk standardized or a risk adjusted survival to discharge rate, which takes into consideration, I believe his team uses 11 different elements that give us a true risk-adjusted survival to discharge. So this will be coming out shortly. I don't have the exact date, but because you're all finishing your 2017 abstraction, I imagine it will be a few months. But if you want to know more about this risk-adjusted survival to discharge report, there's a wonderful webinar that I'll show you shortly that describes everything that is put into the indices that are taken into consideration to come up with this number. Any questions on the home page or things where you've had trouble? *6. All right, we're going to go into reports. Kind of a nice thing that most people jump right to configurable measure reports, but don't forget about this frequency of events report, which is just a handy snippet report where you can see a lot. Now, this is a test database, so it doesn't have a lot of stuff in it, so I'm going to go back way back to 15 just so I can show you how the report looks. All righty. So the cool thing about this report at a glance is it gives you an overview of what kind of events you've had, what units they were on, if you have completed them, the day of the week. This is, again, something if you want to just look at all the things that are happening on Friday night, Saturday, Sunday. You can export to Excel. You can organize them by the top categories. So if you're wanting to get an idea just at a snippet level without running any complicated report, you even have your CPA event survival so that you could look at all those that didn't have survival, so you could evaluate them however you'd like to do that. So that is a frequency of events report. So back to reports. That was frequency events right there. Configurable measure reports. Now, this is where we're spending a good amount of time. Again, right over to the side, there are your measure descriptions. You can see what's in the measure, what's out of the measure, very important, as well as something used to be a measure and it's historic. We're using that right now for airway confirmation. Again, I'm going to put in a broad category so I can show you some filters. All right. Let's just look at one measure, for example. That's a new measure, so I'm going to use the time to shock. You can pick a single measure. Of course, if you wanted to look at all your recognition measures, you would just pick this one group, and it's going to run all 4 reports for you. Let's just do that real quick. We're going to have a bar chart, and you can, this is those benchmarks. This is where they're coming from. They're coming from that front page, or if you're in a system, we're creating them. So let's just compare to all New York hospitals. You have to do control to get both. Oops. There we go. And so you can do your comparisons to whoever you'd like to compare to. Of course, you won't have New York because that's not our affiliate, so you'll have your own state. Oh, now you know I didn't aggregate there, so that's showing me individual. I apologize. You can look month by month. My demonstration data is not good enough to be able to show you that, so I'm going to aggregate so it's all one piece of information. So here you are with your time to first shock compared to the state. Again, demo data, so not as fun as real data. But then that gives you that. You can look through each of your each of the measures, your epinephrine measure, monitor to witness, and then here's your confirmation of airway placement. And so you can be able to look and see how you're doing. Just a reminder, this year, because confirmation of airway placement included a broader group of patients, that if you are not meeting that for 2017 data, you can actually select the historical measure. Let me get that for you. Notice they're here in historic. We just want my hospital, historic merit measure, airway device confirmation, historic, and then you would run that. So that can actually be an alternative to that fourth measure, is if you run this. All right. Now, something else you can do, we'll go ahead and close that out. Let's just go back to our time to shock. You can go down and filter. The beauty of this is if you are keeping track of this, you can look at, for instance, time to shock by the day of the week. Are you missing it on certain days? So here I'm using control, selecting all the days of the week, and I am using compare. So again, generate the report. If you're keeping track, if you have that information, then you will get a report that shows you by the day of the week how that's looking overall, and then how that's looking Sunday through Saturday. So you can look and see, is the time to shock specific to a day of the week? I might also be, and one bug in this, and I don't like it, is that you have to take the last one off with control so that I don't have any mark there. I can also be looking by unit. So if I put in the location where it's occurring, and these are be specific to you, then I want to compare those. I can see how my time to shock is by unit. And again, this isn't real data, but it gives you an idea. So I would end up with a report that's got each of my units where these may have occurred. So that really gives you some good information about which staff might require additional mock codes, which might require other elements related to other interventions related to time to shock. It also could be the location of the code cart. It could also be that the code cart is different than the rest of the hospital, so people are going in there and that's slowing them down. So that's that process of kind of figuring out through a fishbone technique or through some other quality mechanism what's going on there. So lots of opportunities to be able to look at each of your measures in different ways by what is put into the system. You have lots of opportunities for optional fields. Excuse me, I have to cough here. I'm sorry. You have lots of opportunities for optional fields, event location, the type of illness, so on and so forth. You can also do it by the first documented rhythm. So if you're really wanting to look at who were these folks between the rhythms. So that gives you an idea on that. So I encourage you, if you haven't, now that you've been abstracting for a while, get with your director of quality for your area, have him or her go through reporting. If there's anything you're keeping track on a spreadsheet separately that's not being pulled out to Get With the Guidelines, let's see if we can get it into Get With the Guidelines. My goal is to eliminate external record keeping where you're marking things down on a chart or something that can't be reported on. So this is just a little snippet of the many things you can do in your PMT. Any questions or things that you've tried to do that you've been unsuccessful in doing reporting? All righty. All right, it's that time. It's that time where I'm going to ask you to tell us what's going on. What strategies have you used to increase MET team? Are you addressing CPR quality on Code Blues? The other one was, what are you most proud of about Code Blues? Really anything that's happening at your facility that you are working on currently that your colleagues could benefit from. So be brave, *6, come off mute, tell us your name and your hospital, and share with us. Who's going to be first? And quality improvement staff, if you're working with any of your teams and you want to jump in and tell what one of your hospitals is doing, that's fine also. Don't forget, I got the nice laminated bags for anybody who's sharing.
Hey, good morning, Cherie. It's Julie. I think in traveling around throughout my hospitals in Colorado, we're really trying to get a key champion person identified within each of our hospitals and really working to get them the appropriate data to take to their Code Blue team meetings to where they can really begin to really see what their data is showing, because I think it is, prior to my hospital starting, they thought that their problems were one thing, but in reality, once they start putting data in, that's not exactly what the data is showing. So it really allows them to kind of dig down into the data and really kind of do a root cause analysis and start working where their true problems exist.
Very important. I'm glad you brought that up, because we don't want you to, I mean, having awards is nice, but none of us are doing the amount of work you're doing with your patients and putting data in here just so you can get a recognition. You're wanting to have better care. You're wanting to improve care. When we have an in-hospital survival rate of 19% on average, there's work to be done. So very good point. Anyone else want to share what they're working on? Okay, well, I'll give you more chances. Something that we're offering to all hospitals in the Southwest affiliate is, in 2015, the Institute of Medicine came out and they announced this, that the average survival rate for in-hospital cardiac arrest is 19%. And you saw in the earlier article, I believe it said it was 18.6 or 19.6. Anyway, so it validated that this is the survival from cardiac arrest inside the hospital. So what we are committed to doing for all hospitals, whether or not you're using Get With the Guidelines resuscitation, is to provide some consultation around your Code Blue group. And it's absolutely free. And what it'll involve is we have created a readiness assessment, kind of looking at all the elements, kind of like our stroke teams do as they're pursuing certification for stroke. They look at who is their champion, who's on their Code Blue team. They look at all of those elements across to have the foundation for their program. So we'll do a readiness assessment, which is actually an online. It'll include an hour web consultation with either your Code Blue group, or if you've got a quality team that's more appropriate, whoever it is. And then we'll provide a written follow-up report, and then, of course, have ongoing support through these quality exchanges. So this is a great opportunity for some free consulting to really get at some of the elements related to your Code Blue team. If you're struggling with getting support or getting your quality numbers to move up high enough in the reporting structure, this would be a great thing to do. And if you are interested in doing this, just pop us an email at swaquality@heart.org, and we will get you on the list to get this started, because we really want to. American Heart is committed to figuring out mechanisms that we can double this survival, and even double is at 36%. So 38%, I don't have good math. So we really encourage you, pop us an email even right now, pass the word on this when we send out the slides, and let's get you on the schedule to take advantage of this. All righty. Well, I'm doing all the talking, but hopefully you can type in the chat box any questions or if you need more information on something. And Michelle, feel free to pipe in if there's something that we can address for the group. I do want to talk to you a little bit about resuscitation quality improvement. Some of you may already be customers of, we call it RQI. But RQI, when we think about that 19% survival, one of the key elements of that, if not the only one, that's why you're working on all these other areas based on the evidence, but one of the key things is the quality of the CPR that's being given. So we have a program, RQI, that has been deployed in a number of hospitals. It's been out 3 years. Our pilot hospital was Texas Health Resources Presbyterian in Dallas. And by doing RQI, they actually reported a 40% survival rate since implementing RQI. So what is it? This is actually the unit that goes all over the hospital. I believe at THR Presby they have 14 or 15 of these. These units are actually around the hospital, and this is a change in culture because what it means is you'll know certification is the same. Everyone goes to a class. But once you need to be recertified in BLS, ACLS, or PALS, you would simply go to one of these units, one of these carts nearby your unit while you're on duty, and you would do a 10 to 15-minute session, and you would do that quarterly. So it takes the whole 2 years of didactic teaching, and it has on the computer, you would do the book teaching. It's all in little bits, and then you would also do the different compressions, both by yourself, in teams, with the infant. And so the change in culture is that your competency is maintained. The science from American Heart has demonstrated that your competence in CPR actually diminishes significantly at 6 months, and at 2 years, you're almost baseline, and especially since many of our professionals don't do CPR on a regular basis, and yet they have to be trained in it. So RQI is set up to do this at your hospital. High-quality CPR is achieved through real-time audio. It actually tells you deeper, quicker, better. It's looking at those 100 beats a minute, and it's giving you feedback. It's really autonomous learning where the machine is giving you the feedback. You can privately train there at the side of the unit, and if you're not happy with your score, repeat it, so on and so forth. We've even found that hospitals who have these, the patients ask, what is that? And that makes them have more confidence that the folks who would do CPR are actually practicing quarterly. And this is the great part, it actually reduces administrative and labor costs. So because we're taking those people who were checking off people in CPR or having people in an 8-hour class, which nobody wants to go to, or doing it off-site, so having to replace them on the unit, this actually reduces administrative costs. And the folks who are doing the CPR now can be used to refine skills with the staff. This isn't a situation where those folks lose their job. It's where they're redeployed as a super user of RQI. You can see that at THR, they actually had a savings of over $250,000 a year. And this gives you a little idea of a small RQI adoption, 500 BLS, so on and so forth. The annual savings there in a small hospital where RQI might cost $45,000 a year, the annual savings is around $118,000. In a great big hospital where you've got, this would be a health system, where you've got 23,000 folks learning BLS, the annual cost to provide that, when you take them off the unit, when you replace them, when you pay for the course, when you pay for the staff to do that, is a savings there of almost over $4 million for a great big health system adoption. So I've told people this is probably the most exciting change in culture that I've seen in my 30 years of healthcare, to actually save money, yay, but also to keep our competencies. we don't have proof for this, but I really feel like as our professionals feel confident that we're also going to increase the bystander rate. And so hopefully in some of our markets, we're going to be able to measure and verify that. So if you would like to schedule a demonstration of RQI, you can email us and we'll deploy the proper person. It's very interesting. I have like and we have the little mannequin that we can bring. Normally these things would be decided by education, but I will tell you, because this is a complete change in culture, it's probably something that has to go in front of the CNO or someone in your executive suite. Any questions about RQI? Star 6. All right. We did want to give, I'm going to turn this over to Julie. While atrial fibrillation is one of those things in our country that is just so predominant, and we do have a quality improvement program that's aimed at it, it's just been there's very low adoption of this. So Julie, will you tell us a little bit about Get With The Guidelines AFib?
Hey, good morning, everyone. I am so glad that you could join us. And, you know, there's such a correlation between AFib and heart failure and heart attacks and, of course, you know, any sort of cardiac event. It hardly seems like any patient comes in with just one comorbidity. There are numerous things on their list when you go to do that history and physical of the patient. And AFib is definitely on the rise, with more than 2.7 million individuals are suffering from AFib currently, and those are just the ones that have been detected. We know that there are a lot more out there that have not been diagnosed, and this number is expected to double by the year 2050. AFib is costing the U.S. healthcare system approximately $26 billion annually. You know, that's right up there with heart failure. And, you know, it's definitely something that we've got to work on as a nation, of getting a little bit of cost containment around this. Each hospitalized AFib patient costs an extra $8,750. And this is also becoming a very big burden with your readmission rates. And this can result in CMS hospital penalties. So certainly it would behoove you to start looking at these patients, as many of the hospitals already look at heart failure. AFib is something definitely that's going to need to be looked at as well. And, you know, just like heart failure, AFib patients are scattered throughout the hospital. They're not contained like maybe your stroke patients are contained in the hospital, your heart attack patients are contained. These patients are all over the place. The patient care isn't always consistent with evidence-based guidelines. We're finding that with our hospitals that participate in our AFib module, that patient care is kind of all over the place. The doctors really aren't following evidence-based guidelines. I think this is something that, as the American Heart Association, we need to do a better job of getting out there and educating hospitals as to what the evidence-based guidelines state, in hopes that we can get a little bit better, more quality improvement with these patients and improve their life. Only about 50 to 60% of eligible patients receive anticoagulant therapy. This is a very scary number to me, because, you know, if those patients aren't on anticoags, we're looking at a higher predisposition to strokes and certainly those heart attacks. And gaps in care result in serious complications such as stroke, which I definitely said. There are 2 times more hospitalizations than non-AFib patients. They're 3 times more likely to undergo multiple admissions, and 5 times increased risk for stroke and 3 times increased for heart failure. So it's kind of that ever-revolving cycle of, once these patients get like some of these big 5 diagnoses that I always speak to my hospitals about, it just becomes kind of a revolving door. And, you know, how do you get ahead of it, or better yet, how do you look at preventing this from happening in the first place? Saving costs and lives with Get With The Guidelines AFib is helping hospitals and hold them to the latest scientific guidelines and changing the landscape in the above 5 main ways, in addition to a robust PMT tool. We do have a patient management tool just like we do with the other modules. Very, very similar, real-time data collection. So you could put your patients in today and then go back in 5 minutes and be able to run your data with those patients included and go back to your team and say, hey, you know, we're falling out on this particular measure. Point of care education materials, you'll find that within your module. Integrated decision report, arrival, discharge, and follow-up care forms. The HA consultant support is available. I cover the state of Colorado. I'm always happy to go out and help my hospitals look at kind of different ways to solve process problems and how we can look to make that a little bit better. And we truly believe that not one hospital, you know, there's no cookie-cutter approach because there are such vast variables in each hospital that we really need to look at kind of the dynamics of what's going on within your hospital, the culture of your hospital, and take all those things into consideration to put together a process improvement plan. This module is cost-effective, especially because it's going to reduce readmissions and comorbidities, and most definitely with the overarching goal of preventing something much larger, such as a stroke or heart attack. Also education, webinars, local workshops, patient education tools, and also there's the public recognition if your hospital achieves 85% compliance on the measures that we've set forth by our science.
Thanks, Julie.
Next slide.
And I think that's, yeah, we just wanted to make sure, we know you're probably like, why are they telling us about AFib? But the fact of the matter is because you've seen the benefit of being able to get your data in and report, as Julie said, this is a great thing to share with your colleagues who work on AFib. So that's why we're telling you, if you could pass the word, we'd love to demonstrate it. There also is an ablation tab, so your electrophysiologists who want to keep track of their ablation procedures and be able to be part of a national registry, that's included as well. So a lot of times that's where it's driven is from the electrophysiologist. So we're coming upon with 8 minutes to go. Want to remind you, coming soon, February 8th, we're having a webinar, the best of scientific sessions, all the award winners in resuscitation. This will probably really get your juices flowing on what kind of science you want to submit in June to consider being presented at the Chicago Scientific Session. So if you haven't seen this come through your email, you should have, but if you haven't, just pop us an email, swaquality@heart.org, and we'll get that sent out. Also coming soon, and I'm going to ask Julie to hop back on here and tell us about Strive to Revive, which is coming to Denver. This is a continuing education program. So, Julie.
Yes, I am very excited to be able to present our first annual Strive to Revive event in Denver on April 12th. And the overarching goal for this is really going to be about doubling the survival for in and out of hospital cardiac arrest patients. We're going to cover everything from pre-hospital resuscitation to post-prognostication. And we've got some awesome speakers lined up. Dr. Paul Chan will be coming in to speak, Dr. Sarah Perman, Dr. Camila Sasson, and you know, you can see on here who should attend. You know, we would love for physicians, respiratory therapists, of course nurses, and EMS, quality improvement staff, and definitely administration. I think that administration is important because as clinicians, you know, your MET teams or whatnot may not get all of the credit that you deserve, and this will give you kind of arm you with more information to take back to them and show them how you can really support your team and why your team is vital within that hospital, especially in a day when we are having so many cutbacks in the facilities. Our Strive to Revive Save the Date went out. If you did not get that, you definitely can email us at swaquality@heart.org, swaquality@heart.org. We will make sure that you get on that list, and our agenda will be coming out very soon. Hopefully we're going to be working on that and get that out next week. So we're very excited. Seating will be limited, so definitely this is one that you will want to sign up for very quickly so that you can get your space. And certainly if you have any other questions on it, I'm very glad to answer questions.
And I will say, good price. Denver's a good place to go if you want to do an up and back. There's probably a way for you to fly in that morning and fly out that afternoon. It's only going to be $50. I think our CEs are 7.5 CEs, both for physicians, nurses, through that. So I encourage you to consider making a trip to Denver, April 12th. Any questions? *6. Something I wanted to show you, if you don't already have it on your phone, AHA Guidelines to Go. Wonderful app available for Apple and Android. So you just pull it up under AHA Guidelines to Go. When you pull it up, your screen will look like the first screen here. If it's pink, now I have chosen to have a lot of guidelines. You may only want to have certain ones, but I have a lot of guidelines. If it's pink, then there is something new. This is an example of when I clicked on heart failure. I clicked on one of these updates, then it will give you another screen that lets you go in all the way into the executive summary, even go to the actual guidelines, also be able to show you what the next screen, actually show you step by step how the guideline works. And then it actually has the links to tools and so forth that are appropriate both for your phone or your iPad. Recommend this to your physicians. Last week, the new acute ischemic stroke guidelines came out. They came out at 12:33, I think, Pacific time. I popped open my AHA Guidelines to Go. I thought, are those going to be updated on here? And yes, indeed, they were updated and ready to go. So a wonderful tool for those of us working in all areas of cardiovascular disease and stroke. So I think we're nearing the end. I would love still to have, if there's any feedback or Michelle, if there's anything, questions that were asked we want to share with the whole group. The most important thing, of course, is we're right at that point where for those of you who use Get With the Guidelines resuscitation, all 2017 data must be abstracted in February and hopefully earlier than 2/28 so that we can just be done with that and you're moving on to 2018. Michelle, anything we need to know?
No questions on the chat.
All right. Last chance, anything anybody wants to share with the group? We'll be sending this out. There'll be a recording of this as well as the slides. And of course, you'll be seeing the opportunities to sign up for the webinar or hopefully to join us in Denver for the in-person session. *6 for anything else you'd like to add or ask. All right, well, I thank you for joining today. And on behalf of the American Heart Association, American Stroke Association, we are so appreciative of the hard work that you do. Every patient that you put into the registry, you saw 6 of the publications that were a result of your hard work. So it not only benefits your hospital, but it also benefits patients across this country and the world. So thank you for your hard work, and I wish you a good day. Bye-bye.